Welcome to the Embodiment Podcast. This show is for you if you see the body as more than a brain taxi. It's for people interested in coming home to the body as a holistic aspect of who we are and how we live. Episodes contain practical tips, exercises you can take away, and interviews with specialists from around the world. I'm your host for today, Mark Walsh. So on the show today, Kain. So Kathy came highly recommended to me by Irene Lyon, who's herself a pretty well-known trauma trainer. And trauma is Kathy's main work. She's super experienced in this, just been doing it a long, long time. Senior trainer with somatic experiencing, got a couple of books out. Just looking forward to this conversation. So Kathy, welcome.
Thank you.
So how did you get interested in the body and trauma specifically? Can you say something about your journey into this?
Yeah, it was. I think what's true for many of us is it was accidental. That was certainly true for me. I had chronic back issues. I was doing my final exams at university. My back spasmed and I needed to find some help. So I went to someone who did a really non-traditional way of working. And it was like a miracle, from one day to the next. I didn't have pain. And at first I thought, well, I'll just take some workshops so I can learn how to take care of myself a little bit better. And then I got carried away, and 40 years later.
Oops. How did that happen? What was the original modality that you experienced?
I originally trained in something called orthobionomy.
Okay.
Which is a very soft technique. It was a British trained osteopath that created it.
I know one person. I have one student who does it and gave me an exquisite bodywork session once. So it's pretty rare. It's pretty rare.
That was my original training. And then, it's the same thing with trauma. And again, I think for a lot of us, we kind of stumbled into it. I was traveling a lot teaching. And one of the common things in the bodywork world is that people bring their most difficult clients to you, and together, you sort of plan and figure out and do it. I do a session on the person. And of course, what I didn't know at the time is those difficult clients are the clients with trauma in their history.
Right.
So I ended up with this sort of weird specialty as a traveling expert from out of town, working with people with trauma. Although I didn't have a name for it, I just sort of recognized this is a different kind of response system than what I was trained to work with. And actually, Peter Levine came to a workshop that I was teaching, and we got talking, and he both asked me to teach in his program and also said, you need to take my program because you need to know about this thing called trauma. I think that's the underlying link with all of these people that you're recognizing.
Yeah.
And at the same time, I was teaching in a somatic psychotherapy program in Australia, where we were teaching people to integrate touch into their psychotherapy practice. Uh-huh. So it all kind of converged into this one thing of having an expertise of introducing psychotherapists to the incorporation of touch into their practice and developing over time the specialty and working with people who had trauma that was fueling these somatic symptoms. Right. So it wasn't a purposeful choice, but it's sure been an interesting journey, that's for sure.
Right. I mean, let's take a step back. I mean, first of all, just kind of remembering a time when people didn't talk about trauma all the time. Right.
That's right.
It wasn't that long ago in the UK, and even in the West Coast there, it wasn't so long ago that was a weird thing to be into. Like, I happened to have an aikido teacher who was also a trauma specialist, and that was just strange. And I don't want to know about that. That's nothing to do with me. I don't need that. That's not to do with me. That's for kids who've been abused or something, And it was sort of like very much, I'm a bit uncomfortable talking about it. I don't need that. I'm not a war veteran or anything. And, I remember that then it gradually came more into the fore. And through the work of people like Peter Levine or David Bittelli or people that have had on the show, it became like known in popular culture.
That's right. And even now it's kind of filtered down to the client level. It was true, even now with clients, I wouldn't necessarily use the word trauma for the reason that you said. For a lot of people, they still categorize trauma as something really horrific. It doesn't have to do with the normal stresses of being a child with parents who maybe weren't like the best parents. It doesn't go along with having car accidents. Yeah. Most people don't necessarily self-identify as having trauma. So I have a whole non-trauma vocabulary that's really about trauma. And I think many of us in the physical care world developed that just because we were seeing the evidence in front of us, and maybe we didn't have a structure for it. That's what was helpful for me in training and somatic experiencing. I then had a structure to understand what I'd already been experiencing as a practitioner I had some vocabulary. I was better able to talk to clients, psychotherapists and neurologists and people like that. But even, in the broader culture, at the client culture, I think still there isn't necessarily that understanding that trauma can come from everyday events.
Right. So this is the big change, isn't it?
Yeah.
So the kind of thing you were seeing was like kind of medically unexplained stuff, or kind of chronic symptoms like irritable bowel or weird skin conditions. That was it stuff that couldn't go away, and you were going, okay, well, it doesn't seem to have an obvious kind of normal medical reason for this.
Yeah, the way it started for me is because I was working in a physical care setting, so to speak. I was working with people who'd had car accidents and falls and physical injuries, and they weren't recovering from their injuries in the way you would expect.
Right.
And even with getting good care, even in the work that I was doing with them, it's like their body is not responding the way I expect. This is kind of confusing. And then they started developing new symptoms that at the time didn't make sense to me, but later made sense, like having sleep disturbances and beginning to have panic attacks and starting to have these symptoms that were away from the physical symptoms that they came for. And they were clearly related to the work we were doing. In a way, I could say I was making their symptoms worse. They were adding symptoms, not taking them away, because I had not yet learned to work in a more refined, slowed down, chunked down way. That's how I learned to work with what I thought of as kind of those clients, people who had sensitivities, people whose symptoms weren't behaving the way that I expected. I started to learn, go slow, take smaller chunks. You can't use some of your regular techniques. You have to come at this a different way. And then I started to see results happening. They are now recovering from their injuries. Those other symptoms are going away, or if they came in with sleep disturbances, anxiety, even though it's not really my job to work with them, they're beginning to lessen. And so I began to understand now, in hindsight, what happens that's different in the physiology under the duress of traumatic stress. I didn't have a name for it, but I could then start to recognize those clients fairly readily at the beginning of the treatment and begin to alter my treatment. And that's kind of where Peter came along to say, there is an explanation for this, and I think it'll help you if you understand more about the physiology. I also see your skills in the touch work being important to help people recover from trauma. So that's when he invited me to start teaching in his program. And then the light bulbs really started going on about why I was seeing these symptoms that even now the treatment culture keeps them separate. We really keep physical symptoms pretty separate from what we name as psychological, emotional symptoms. Mm-hmm. So someone with anxiety would not necessarily find their way to a physical care provider.
Right.
But now we understand that anxiety can be a side effect of that disrupted physiology. But that was certainly, this was in the early 80s. That wasn't on any traditional care map at all. It was all the non-traditional people like Peter, like those of us in the sort of bodywork world rather than in the strict physical therapy world, that was working more in hospital settings. It was those of us working sort of at the periphery that were experimental, that we started, I think, making these kind of connections between these. Like anyone who's worked in the physical care world for any period of time knows that chronic fatigue, fibromyalgia is affiliated with trauma. We put those pieces together 20, 30 years ago because it was such a common symptom cluster to see people with these kinds of attenuated responses and having autoimmune disorders and having these kind of weird pain systems. Those of us in this side of the field have been working with pain syndromes and autoimmune syndromes as a side effect of this early impact into the person's physiology forever.
It's interesting. You've come at it almost the other way around, haven't you, from a lot of the people we've had on. You weren't a psychologist. You suddenly went, but we have to include the body because the body keeps scores. We have to include that. You were a physical person working physically, as I'm hearing you start going, well, hang on a minute. We keep seeing this. We keep seeing this.
That's right.
When I asked people, it turns out they had some, difficult childhood experiences, and this seems to be a common grouping. So
for me, it was like, well, they live in the same house. I don't understand how that all works, but they show up together and they show up consistently. And somehow we have to figure out how to address this very often for me, it was a team approach because, again, in the care delivery system, we divide these jobs. So I'm not, as a body care helper, I'm not in a way allowed to work with the psyche, even though, of course, you have to. What I always say to people is it's always in your scope of practice to be a human being.
Right.
So you can be caring to people and listen to them and respond to them as a human would. And that's in your scope of practice. And then if the psychological, emotional issues are driving things more, then you maybe need to get somebody helping from that field. And that's what I did. And that's how I learned. I started calling on colleagues who were psychotherapists, who were medical practitioners, to just figure out, what do I need to do that's different with this person, and who else needs to be on the team to be helpful to them.
Yeah. So it's that split. We talk about body-mind split, but it really is, as you say, it's in the professions. Like psychologists often aren't allowed to touch people, and the touch people aren't allowed to psychologize people.
I know. And there's the poor client who's getting divided up that way, even though it's what's happening for them is not inherently divided. And we're just, I'd say within the last 10 years, because I've been training psychotherapists to use touch for 30 years now. So I've watched the field change. And it's maybe in the last 10 years, we're starting to have a profession that isn't yet identified as a separate profession that can help people with this version of trauma, where they have deep somatic symptoms. Whether these people are psychotherapists who know how to use the body, whether that's touch or not, doesn't, I have a preference for touch, but at least include the body, or whether that's body therapists of various kind, including doctors, medical care providers, who get that the body is expressing more than just a mechanical physical disorder. We're starting to get now some treatment that allows the client to have all of those symptoms be known as related to trauma, and that their somatic symptoms have meaning for them. Because that's the other thing. My clients would come in, they report these things as if they were just about their injury.
Right. I had a car crash and now I've can't sleep. Or
that's right. Or even they wouldn't normally make those connections. I have a car crash and I have pain, and then somewhere along the line they would mention that they couldn't sleep, or they might mention that they had anxiety, but they hadn't yet put them together.
Got it.
With the car crash. And now there's more of that information available at the client level. But even then, there's a big education piece that most of us need to do for the client to understand those are all in the same category of symptoms.
Yeah.
They're all symptoms of trauma.
It's tricky. Like, I was having this conversation with my sister. My niece has got ADHD, and she had a very traumatic early childhood just because of physical things. No fault of my sister's at all. Just illness she was born with. And I said, maybe these things are related. And that was my sister didn't want to hear it, I was like, whoa, okay, some sort of stigma was still there for her, It was like, hey, maybe this isn't just a random genetic thing, but it's still tricky to make that link sometimes.
And that's often why I'm not using those words. I'm not using the word trauma. I talk about scary things.
Then this is let's hear some of the vocabulary, because I think it would be helpful for me.
Yeah, I usually just talk about scary things that happen to us.
Okay.
Things that are so frightening for us that the organism has a big enough response that we feel challenged to deal with it. And everyone can identify with that. And then I talk about the aftermath, and it's like we think of that as being only in our mind, but our body is responding at the same time. It's pretty straightforward.
The language is really important, actually. I had someone 2 days ago say that I traumatized them. And my immediate response was to get defensive, because I was like, well, I didn't do anything. I didn't hold them over a cliff by their ankles or something. You know what I mean? I was like, first of all, I think they just meant they were a bit upset. But I mean, had they said to me, hey, I felt really overwhelmed when we had that conversation, and I froze up and I didn't really know what to say to you. And it's still with me a week later, that I've still got a funny charge around you, Mark, when I see you now, because I felt really overwhelmed when we had that argument. I would have been way more amenable to that conversation than you traumatized me. It was the language really matters, doesn't it?
And this is also why, in a way, the word trauma is starting to lose its meaning, because people are using it for things that are normal human interactions.
In Portland, Oregon, Kathy, surely not. Surely not.
So we need to be a little careful about not naming things as trauma. People talk about birth trauma.
Yeah.
When really it was, I mean, birth is stressing, true, physiologically, but it isn't inherently traumatizing. Something has to kind of go wrong and not have an immediate repair for it to really be categorized as trauma in the way that we would be talking about it.
Okay. So
having an argument with somebody and you feel
Yeah.
upset is
Yeah.
not inherently traumatizing.
Yeah.
However, if you have a history of abuse and violence in your family and your response is to feel absolute terror and helplessness and hopelessness, now we've got somebody who's got a trauma response being triggered by that interaction.
Right. And there is a word about words being belittled, like triggered and trauma, like they have quite specific meanings, don't they? And they can be sort of, I think, deep, like what words are left if those words are used for everything? And
That's
I think
right.
that becomes a real problem for people who are, survivors of serious stuff, is that they lose the language to which to talk about it when that language has become so commonplace. So I'm quite adverse to that language for the sake of that, quite adverse to it. But any other ways you talk about it? It's like Irene sometimes talks about nervous system health or nervous system regulation. I mean, that seems a fairly, healthy, easy language to talk with. Any other ways you discuss this?
I think that it's another version of not really caution, but understanding that the average person does not have this vocabulary.
Yeah.
I mean, the average person is not going to know what their nervous system is doing. They haven't even thought about their nervous system ever.
Yeah.
And many of the people that I worked with were people not from this field. Some of them were psychotherapists, but many of them were people who had no contact with this field otherwise. And so they didn't already know about the autonomic nervous system, the polyvagal theory, even the physiological impact of stress. So slowly, the education might happen. So by the first 6 months or a year of working with them, they could talk about their nervous system and all of that. But in the beginning, that language for me often wasn't really helpful because the person didn't know what it meant. So we might talk about what they experience, and I would be maybe talking about what they notice their breath is doing. How are they sleeping? I have many conversations about poop. Like how often are you moving your bowels every day?
What would be the trauma pooping then? Would that be people who are constipated or are pooing all the time? I mean, what's the...
So what we know at a technical level from the polyvagal theory and what happens in the autonomic nervous system is one of the main systems that gets kind of set aside when we're in a high stress event is the digestive system. We stop digesting our food because we're fighting for our life. Who cares if we make use of lunch? And so the digestive tract is one of the first places that we do something with it when we have stress physiology on board. And so it's one of the main places people will have symptoms that they haven't even thought of as being trauma symptoms. Are you always constipated? Do you have chronic diarrhea? Do you alternate between constipation and diarrhea? What we know technically is that means their vagus system may not be giving the right instructions to the muscles of the bowel. Or neurochemically, they may be living in stress chemistry, which is giving them this symptom. They've never considered that. It's like, well, I've never pooped right. Yes, but you had trauma from when you were a kid. So, and they don't even know what pooping right means. I go so frequently, I go like twice a week. It's like we don't talk about poop in our culture, so people don't know how.
Let's talk about poop. Let's get German on it. So, what is a healthy amount of poop? Is it sort of once a day, every time you have a large meal? I mean, is it just like a chew?
Yeah, both of those. Yeah,
well,
that's kind of approximately once a day.
Couple of times a day myself quite often.
And some people poop right after a meal, but once a week, not so regular. Like 5 times a day, runny stool, probably not so regular. And so I'm asking those kind of questions so that we're linking these physiological states that the rest of us at a technical level understand to the person's daily experience. Do you wake up tired? How many hours a night do you sleep? Do you feel invigorated? Do you feel like you take up the nutrients from the food that you eat? Do you make use of those nutrients? Do you have energy to do other things than just managing your daily life? How many practitioners do you see? Does it take a lot of support and care to keep everything functioning? I have those conversations rather than trauma conversations. It's like
Just on
I didn't realize that not pooping could be related to these other things.
Yeah. I had a client years ago for coaching who just had real constant diarrhea issues. I had no idea. And she said, look, it's not really your domain. You're a coach, but I should mention this is why I keep running off to the toilet, during the coaching sessions. And I said, oh, what's your background? And, she was from a family of Holocaust survivors and on both sides. And I was like, wow, okay. She hadn't ever made that link between the fact that she had this huge trauma in both mum and dad. Right. And she had these digestive issues, and I just sort of said, maybe consider talking about that with a therapist or making that link. I mean, you're
if a therapist has made the link,
now hopefully they would, but this was nearly 10 years ago. But I mean, you're mapping sleep, food. I guess what are the other major physical areas, like aches and pains, like people that have these like pains and aches, and then immune kind of system stuff, like. I've known people that were just constantly getting ill who had trauma backgrounds. Like, I've got a little bit of a cold today, but that's pretty rare for me. And I know people that have just always got a cold. They seem to just have that rundown immune system. Are these some of the other physical areas? Yeah, I think and again, you're hearing the language that I use with clients as we're moving along to get them this education. And I talk about it as essential services. The things we can't live for an extended period of time without doing. So we've got to have digestion, we need to sleep, we need to repair tissue. So that means the immune system, we need to be able to fight off infection, immune system. We need a barrier to the outside world. So our skin, what is our skin up to? The breath, the heart, like what's your blood pressure like? Not because I'm taking a medical intake, I'm just trying to get this translation from the technical material of the physiological disturbances and their daily life experiences of things that they maybe haven't identified as being related. So do you have breathing issues, blood pressure issues, sleep issues, digestion, immune issues, the essential stuff? And do we have evidence that some of the essential stuff is either strained or being set aside because more critical things are happening? Right. So as you're talking about with the person that you were coaching, I'm in the middle of doing something that's important to me. And maybe even because I'm a little bit stressed about it, my bowels start to now be overactive. And so now that's cutting me off from the activities that otherwise nourish me and help me. Or maybe now I can't digest that food that I took in because it's run through my system too quickly. So I can't make use of the nutrients. So whenever we see a kind of reallocation of body resources, I might be asking someone, are you the kind of person that doesn't heal a wound very quickly? Especially if somebody's had an injury, and I'm watching to see those scabs have been there now for like 2 months. They are so slow in their wound healing. I can tell their immune system is occupied somewhere else. It's not, do they not fight off colds? Yeah, so people that just don't get over normal stuff. And
that's right.
That's why I always scratch my clients on the first session just to check. I mean, is there a risk here that we could be seeing everything as trauma? Do you know what I mean? Is there a risk where, like, oh my God, my wife's got a cold, she's got to have trauma, that, oh my God, I've got the squits for a couple of days, like there's a bit of a risk here that it becomes what we see everything. But I guess you're looking for stuff that is unusual, right? Like always having repetitive stuff.
Maybe what you're looking for is the combination of the trauma history and these symptoms, and particularly when the symptoms have not responded well to traditional treatment.
Got it.
You're starting to see a pretty convincing picture. Now, we have the adverse childhood experiences study now. Those of us in the physical care world have been doing happy dances now since that information started coming out, because we all pretty well knew, but certainly suspected that a lot of physical disorders are at least related to trauma. If they're not caused by it, they're made worse by traumatic stress physiology. This is the way I talk to my clients. Everything is made worse by stress physiology, especially neurological and immune disorders. Stress physiology is really bad.
Physiology, there's another phrase. I don't mind me interrupting. I just want to underline that. Stress physiology. That's right. Another nice way of talking about it.
Yeah, because that people get. When I feel stress, we don't have to talk about traumatic stress. It's the same basic kind of physiology, just at the extreme end. And the adverse childhood experiences study specifically correlates adult diseases with early trauma. And so then you get this list: heart disease, diabetes, lung disorders, autoimmune disorders. And what we're starting to see is it's actually very difficult to tease apart what is the genetic predisposition that would have happened no matter what, and what is a genetic predisposition that's been turned on by trauma.
Yeah.
Had we not had the trauma, maybe we wouldn't have expressed that predisposition. How do we know now? So we have to be careful to not decide everything comes from trauma, but we also need to know that many things can come from trauma that our care delivery system has made separate. Right. This is like a revelation in the medical world that has still not landed, even within the Kaiser Permanente system, which is where the research originated. They are not using trauma-informed protocols everywhere. Yep. Your doctor should be saying to you when they're doing assessments for heart disease, diabetes, or anything,
right,
they should be asking the 8 original 10 ACE questions. Have you had exposure to early events? And they're specific: sexual abuse, incarcerated relative. They're very particular. They should be asking those questions so that they understand there might be more fueling this disease than what they thought before. So that's really looking at that combination of trauma and these disorders, because we can all eat the wrong food and have digestive upset. We can all have a predisposition towards a skin disorder and may not come from trauma. So in the absence of a trauma history, it's not the first place I'm going. I'm asking them, have you seen a dermatologist? Have you seen, it's not very convincing if they have a benign history, no accidents, no big surgeries, no big stressors, and they have these kind of symptoms. But when they start happening at the same time, we should be at least a little suspicious.
Yeah. So kind of clusters of symptoms, maybe not responding to normal medical treatment, and and maybe also asking those questions of like, hey, how was your childhood, kind of things. So it's like, okay, a pattern starts to emerge here.
And again, in terms of the language that I use with clients, the basic narrative of early trauma is essentially, with just the details being different, something bad happened.
Yeah.
And the people who should have, could have, would have been there to help were unable to or didn't. Right. That's just it. It might be they were the source of the abuse. It might be, as you said, with your sister, is that the parents were doing their best job, but circumstances conspired to mean they couldn't get to the kid to be as helpful as they needed to. Or there were repeated procedures that overcame the helpfulness. Finally, the helpfulness was no longer enough to be the remedy for the stressors that kept coming into the child's life. So it's not always abuse and neglect that is the source of it, but something bad was happening to us and we didn't get the help we needed. And that's just kind of the recipe.
Yeah. And it's nice to have these sort of, as you say, recipes that you can say to people like, hey, what I use a lot with clients is like with embodiment or personality stuff. I say, hey, you developed a pattern. It was adaptive to where you were then. It was the best you could do at the time. Now it might not be so adaptive. You're always going to have it as an option, but you want to learn something new. And that little recipe makes them go, yeah, okay, great. They can kind of roll along with that. So I think it's nice to have these kind of recipes, as you say, for saying, look, this is normal, this is basic, and this is how we got to where we are now.
Yeah. And we don't have to use the word trauma. And every person, when I've had that version of the conversation, to say, that's pretty much how my life was. For whatever reason, it's like, you wouldn't be having the responses you're having now if that wasn't the history, because you would have developed resilience. You would have been able to respond to the stressors in a different way if everything had gone well. It's that pre-stressing thing that happens with early trauma makes you more susceptible to later stressors. So then you will have a bigger response to that car accident than someone will who had everything supporting good resilience. It's sometimes just the luck of the draw, and things happen in just the wrong combo to recapitulate your early experience or to overwhelm everybody's ability. After the 9/11 attacks in the US, everyone was out of their mind. Everyone was overwhelmed. This was too big an event to take in for any of us to meet it with complete equanimity. An earthquake, I'm originally from California, a big earthquake that shattered people's houses and, you're unsafe because there's aftershocks. We're all going to feel these things.
Mm-hmm.
It also happens in coincidence that you've lost someone that you've loved, and you've lost all your belongings, and now you've lost your job. And, almost any one of us could have a combination that will overwhelm our ability to cope with it, even when we're really resilient.
Yeah.
Yeah,
a therapist friend of mine works with people who've been in bank robberies, and he says it's sometimes quite surprising which bank teller gets the PTSD. And he says it could be just that one's not had a good night's sleep, broke up with their girlfriend, and then they get the bank robbery.
That's right.
Whereas the one next to them hasn't. You know what I mean? So it's like this is a particular set of conditions that mean that bank teller A gets PTSD and bank teller B, who also had the gun pointed at them, just doesn't. So it could even be what's going through their head at the time, right? Like there's factors there that are a bit mysterious. So in terms of what Peter Levine added then to you, so you're seeing these patterns, he came along, what gave you some more language around like some of the trauma processes? What was the... Listeners may have heard other episodes with trauma teachers we've had on. They're some of the most popular ones, actually, some of the most popular episodes. People are interested in this topic. But what are some of the sort of very basic things? Is it all those things we've just covered? Or maybe I don't want to take a step back here in case we've missed any basics for people.
I think that at least I can speak to the difference from myself. And this is not only from Peter Levine, but also with Steve Porges, is to understand the architecture in a different way. I was taught a system, a bodywork system, that basically presumed normal physiological response. And what I was seeing with my clients is I'm doing that, and they're not responding the way they're supposed to.
Yeah.
So I knew something wasn't the way I had been taught, but I didn't know what it was. Then I encounter Peter, I get to the training, and I realize, we have abnormal physiology. Traumatic stress physiology is considered abnormal physiology. It creates eccentric responses.
Okay, so you mean like unusual responses, like, hey, this wound isn't healing, this digestion is off. Yeah.
Or I'm doing this movement, and normally the muscle would relax when I do this movement, but in this person, it's spasming. Yeah. That makes no sense from what I was taught. This thing that I'm doing should cause that muscle to relax, but instead it's spasming. Now, what I didn't know is maybe I'd inadvertently put them in a self-protective posture that reminded them of the injury. And their organism is going, oh my God, I have to protect myself, and goes into bracing. And I'm on a different map. I'm on we're going to just make your muscle relax map, not on your organism is feeling compelled to protect itself. So of course it's going to grab the muscles and contract and get ready. So that's the biggest step for me, is to understand, there's a whole other job that the organism is doing under the influence of this physiology. It's protecting itself. It's conserving its life. It's doing something more important than relaxing the back and letting your neck go. And it was really just taking this and mapping it over to then have the aha of, now it's making more sense why I was seeing those responses in the client. And basically, I just kept scaring them every time I saw them. And so their organism then couldn't sleep and started having anxiety, because I kept reminding them of the danger experience without giving them any resolution to it.
So this is the real meaning of the word trigger, right? There's a strong association with a traumatic event, which is then re-engaged. Yeah.
That's right. And maybe, the trigger isn't necessarily a bad thing if we then bring some level of completion and resolution, and they move back out of that response system in a way that means it's not as likely to be triggered in the future. That's kind of the model of some trauma therapies, is to do that. So that was the first piece of the puzzle, was I need to be looking at this from another perspective for these clients, because I'm asking them to ignore the urge that's moving them towards response to danger when I'm pretending it's not in the room while I'm doing work with them. And now what I need to do is invite it in the room and say, we're going to complete what that process was that got interrupted and let your system come back. I call it reset to zero. We need to reset back down to zero. You're operating at a 7, 8, 9, 10. And I'm saying, just relax, everything's fine. And organismically, the person can't get to that information. So we need to get back down to neutral. in order for then the just sort of straight bodywork techniques that I was taught to be effective, and they will be, but not in an organism that is really fighting for its life in this moment in time.
Right. They're in a survival mode. And I think that can be really a great door to compassion when I say, hey, this person's in survival mode right now. You know, this person who's having a go at me on the internet or upset with me about something or, you know, scared of me in a kind of way that just looks kind of weird to me, you know? Like what do we do? And this is it's kind of a personal question. I tend to trigger my just embodiment is quite physical, quite, you know, I'm blokey. I move in a kind of blokey way. Do you know what I mean by blokey?
Yep.
And I've got quite a sexual vibe sometimes. And even if I'm being completely, you know, boundaried with people, they can get triggered. I mean, I've seen this happen on silent meditation retreats. Mm-hmm. So it's really just my physicality as a guy is somehow triggering people. And I go, what do I do with that? You know, like, or as an authority figure, like if I'm teaching a group, people might, and a lot of listeners I think can relate to this one, even if they don't have my embodiment, is that they'll be teaching the class. And then, for example, there was these, I was teaching some young Russians the other day and I was on a Skype call with them. And I said, right, next time I'm in Moscow, I want to do a thing where I look at you guys and I evaluate your teaching and I give you some feedback. And they took it to be like, okay, Stalin is going to look at us and punish us and send us to Gulag if we're not perfect. And I can see them all going through a freeze response. I'm like, guys, it's chill. I'm here to help, you know? And, you know, they were projecting this weird authority, trauma, fear, I guess, on me. Like, what do you do when you have this thrown at you and it's not really you that did it, you know?
Well, I've learned, you know, I've been teaching for almost 40 years. So, of course, this is going to happen. It's no matter what, you know, people will place you as the authority figure, whether you are behaving that way or not.
Sure.
So for me, there's two basic versions of it. One is, you know, it's just going to be the slippery Teflon coating thing where there's nowhere for it to stick.
Yeah.
And that's not always easy because, of course, it elicits a response in each of us, where we are going to marshal our own response, whatever those habits are for us, either appeasement or our own aggression in return or whatever, you know, trying to make them understand us, which of course causes them more fear.
Why did you not understand them, not Stalin?
Exactly. So one of the things that I've learned is to work with my own response to that, to get to know when, and for me, it's actually almost like a physical sensation of gathering. It's like a gathering towards a particular response. And the moment I notice that in myself is the moment that I kind of step back, take a breath, widen. My rule, like with clients and in classes, when they go up, I go down. So as they escalate up into their response, whether that's fear or anger or whatever, I go down and wide. And I'm going to be the river, you know, like go out into the calmer flow of the bigger context is like, this is, and it gets easier for me, and maybe you have the same experience. I'm on to the next workshop in a few days, or, you know, like this is a moment in thousands of moments that occur in the course of my work year. I'm assuming it's a sort of similar thing with ER physicians and people where they're exposed to stuff that would terrify us, but they're exposed to it on a day-to-day basis. So it becomes kind of routine for them to not have their big responses unless it's over a certain kind of limit for them. And I know in talking to medical professionals, there will always be something, a kid comes in, or there'll be something that gets you at a personal level.
Yeah.
So then there's like the self-compassion about the fact that, well, I didn't respond to that as I could have. So for me, it's just like widening out is like, this is one experience in the thousands of experiences. And I don't have to take this one personally, seriously.
Quick interruption to tell you about my book, Embodiment. Creatively named, hey? Actually, Embodiment Moving Beyond Mindfulness. You can find this online at theembodimentbook.com. That's theembodimentbook.com. So this book is an introduction to the whole field. If you like these interviews, you'll probably love this book. Funny stuff, poems, personal stories from my life, illustrating what embodiment's all about, and loads for professionals in the field too. Top teaching tips, language tips, that kind of thing. Yeah, a real condensation of everything I've learned about embodiment, basically. So you can get pre-orders at Amazon.com, and if you just put in Embodiment Moving Beyond mindfulness, that's the name of the book, or go to theembodimentbook.com. On there, you'll see quotes from various teachers, a bunch of fun illustrations, and you can also get the first chapter completely free online at theembodimentbook.com. Enjoy, and back to the interview. When you see a pattern, for me, there's a sense of like, okay, if there's a pattern, it's not personal. It's like, there's that fish hook being offered again. Do I want to bite it or not?
That's right. And then the second part of it is, as you said, so if I'm taking this, as it inevitably will be, as actually primarily historical, because in that moment you are not a threat, you're just being yourself. And so if I have a big open filter, I'm going to just notice you're being yourself in a certain range that, gets to be included. And so if somebody's reacting as if that's not true, that you are judging them or whatever, it's based on their historical experience that has accumulated to get their response going in that way. So I can do as best I can the same thing and kind of open out to recognize you don't behave like that if somebody didn't hurt you.
Yeah.
You don't behave like that unless somebody already judged you and made you feel unsafe about observation or something. And then that can elicit my compassion response.
It does elicit compassion to go, this comes from somewhere. It has consequences for you that aren't fun. It's not really about me. Like every time I remind myself of that, it's just real easy to work with. And I think maybe also some of us are just not suited to healing work, just typologically. Like if I look at, say, Stephen Porges, Pete Levine, David Baselli, they have a certain way of being, right? And it's like they don't look like the guys who I grew up with. And I wonder, and I'm not saying anything bad about any of those guys, great guys, but it's like their manner maybe suits that role. And or my own teacher, Paul Linden, he's a little old man. He's kind of cute. He's unthreatening in a way that I'm not, and it's like maybe at 60 that, it'll be easier for me. So there's I think there are just some sort of like, are we typologically suited to this work, or are we just going to walk into a room and set off fireworks left, right, and center? And
is that necessarily a bad thing if that happens? Because you got something. I trigger people all the time. I have kind of the equivalent. Well, I'm relatively tall as a female. I'm not actually very interested in other people's opinions. And I've been doing this a long time. And so when people want to give me feedback, unless they've been doing it a long time and have a certain level of expertise, I'm not very interested in it. I'm not very prone to appeasement. So some of the things that would make things easier when you are in the facilitator trainer role, I'm not very inclined to.
It's just not
No, and so it pisses people off because, of course, on the other side, what people want to know is they give you feedback. They want to see an effect of that feedback on you. I'm perfectly willing to hear the feedback, but it just may not have any impact on me that's noticeable to them. It's like, well, that's interesting, but I've heard that 500 times and I'm not doing it any different. Thank you very much. And that triggers people. Because then they go into their, I'm invisible, no one, I'm not heard, I've just been annihilated, I've been, like that.
You're saying the opinions of every sensitive Portland resident aren't vitally important to take on board, Kathy.
They might be very...
We're not allowed on this show. That's...
They may be very disappointed to hear that's true.
Okay, I'm liking you more already. So this is good. Okay, another bit of a random one. I'm going a bit random here. I hope I'm not wasting your time. Evolutionary. I'm trying to think how this developed. So I'm imagining these, let's call them cave people for political correctness, and these cave dwelling humans. They've got tigers going on, they've got starvation, they've got childhood mortality. It was a pretty rough life, I imagine. I don't imagine it was some sort of idealistic life, getting predated by saber-toothed tigers and things, and wondering if you've got enough food to get through the winter. Pretty rough. And cappuccino hasn't been invented yet, so I'm imagining in that environment, do you think they were all traumatized? Or do you think the opposite, that actually there was certain things like tight social cohesion, that we lived in hunter-gatherer bands of 100 people, and we probably had a lot of what we would now call social support. Like, I'm trying to imagine how this evolved, because it seems like otherwise it can seem like a very first world problem. Does this make sense as an inquiry? I'm
Yeah.
starting to, I was reading the Iliad the other day and I was like, okay, it looks like Achilles has PTSD, but does he? Do you know what I mean? He lost his lover and he's upset. So it's like, was that really a problem for ancient humans?
Well, I think this is a big debate, which is really very fun to listen to because in a bigger way, it's irrelevant for the work that I have to do. So it's like, all right, could be that, could be this. But it does seem that there is a functional reason for vigilance to have value. I would assume the more vigilant ones are the ones who survived of whatever species. And so now we just have an environment that we're no longer in relationship to the natural world. So we have an environment that has so much demand on decision-making, on assessment, on figuring out is something dangerous or not. Yeah. The exposure level to new circumstances is so high now. I don't know how functional that old sorting system is, because in the natural world, there's only a certain range of potential dangers that we would likely encounter in our lifetime.
Yeah.
And I mean, I'm sure you do this too. I get on airplanes and I go to different cultures, and some of it's like, well, I'm not exactly sure what I'm seeing here. I don't know how to take in the information. I don't understand the language. I don't understand the body language.
Forget other cultures. I think things are changing so quickly in the modern world that like we've made jokes about language and language policing today, but actually to get the words right in a way that's not going to offend and upset people is quite tricky, because it's changing every few years, So I think the cultural environment, the political environment, everything there's a speed and a complexity and a confusingness of even the last 5 years I've seen this increase. And I wonder in that environment if our nervous system is well adapted.
Well, and I think then you said the other part of it is that all of those things that we would have been doing would have been happening in the context of a known social group. We didn't live in groups of 100,000 million people. Yeah. We lived in small enough groups. I grew up in a small town. You kind of knew everybody. Yes. You knew them on sight. You didn't necessarily know them personally. But there I am, in the grocery store when I'm 16 years old, and the clerk is saying, I remember when you used to come in here and you couldn't see over the counter, And so you knew the people and you knew their behaviors. You understood this person's going to do this sort of thing. Yeah. And we just as a group have to kind of figure out how to integrate that way of being. And here's a person that's going to do it differently. But it was kind of a known group and there was a cohesiveness. You showed up for each other, under duress, whether you like the person or not, you were going to be helpful to them. That's still small town life. Mm-hmm. I'm sure it was more in more earlier cultures. That was just the way you survived. And now that's also fragmented. And some of us are growing up in households with one other person. And we have a single parent. We don't have a group that's helping us. We don't have, if that one person is stressed, so are we. We don't have aunties and uncles and other people to go to in order to help mediate the stressors that are present. And I feel like that's a big piece of the puzzle, is that this fragmentation that's happened in so many different cultures where we've lost those family bonds and the social bonds that would help inoculate us against the development of stress. I think, we could just say that stress of any kind, whether traumatic stress or not, is rampant. It's just increasing. It's not decreasing. And the way we're going in
the sort of social critique of stress from an individualistic point of view is, I think, really necessary, isn't it? That kind of looking at it from the bigger point of view.
Yeah. And so then you have, I just think in a way you're propagating trauma because you have someone who's actually not resilient. And we're just producing, we have at least 2 generations of young people that probably don't have the level of resilience that the previous generations had, even though they might have been exposed to war and other challenging things. We certainly see physically, we have our first generations coming through that have a lower expected lifespan. And because of obesity, we're starting to see the toll that's being taken now in the way that we are living our lives, certainly within some cultures, not every culture. And one of those is this isolation piece. And so now you're going to have people more prone to responding to stressors in a traumatically stressed way.
Yeah.
Because we just don't see that resilience.
Yeah.
And I think it's like a pig in a python. We're going to start to see an increasing number of people who have these symptoms that we affiliate with PTSD, but we're going to look at it and say, but nothing's happened in their life that should be producing that.
Yeah.
Because I think we now have people who can't even respond to normal life stressors, like day-to-day life stressors.
Right, I see this all the time, just like even like colleagues or friends that just have a little thing go on and they really can't take it. And I don't know if this is a sort of almost comical kind of running away from things and disposing with people and cutting people off if you have one little row. I've come across this increasingly. So I think it's partly disposability culture, which you don't get in a village, and partly sensitivity, partly just going, you know what, like I just literally cannot handle this. Like even if it's a relatively small, like minor disagreement about a work thing. And I've increasingly seen this in the last few years, and I was a bit disturbed by that. And have you seen Joker yet? The film Joker?
No.
Really recommend it. Anyone interested in trauma? It's all about how sort of society breaks someone down and takes someone, early childhood trauma, and it shows really well put together and amazingly acted. He's even got the sort of somatic things going on. Highly recommended. Okay, so as I don't sort of waste your time, I feel like we need to make good use of you.
Okay.
What Kathy, is yours? Because we had different trauma teachers on. What would you say is your sort of house specialty? What is your this is the thing that I kind of do world class that I'm very focused on?
I would say the main thing that I do well that is not as common with other people working in this field is the working with the somatic effects of trauma, particularly early trauma, where it's hard to name it because it happened so young. Mm-hmm. So the client population that I worked with were the people that had seen 50 practitioners, they've gotten all sorts of medical care, and their symptoms haven't changed. And they have, in many cases, very serious symptoms. They have not only what we would classically think of as the psychological symptoms of trauma, things like anxiety and that sort of thing, but also really big physical symptoms, digestive issues, heart irregularities, a myriad of what we think of as genetic disorders like diabetes, that sort of thing, often in really poor health. And that is a client population that's really misunderstood. And they're very often shamed that they're malingerers, that that's all in their head. Yep. Because their symptoms are odd very often. They don't make sense from a kind of classical perspective. And very typically, they don't respond well to the treatments, the normal treatments.
Right.
They have paradoxical responses to medications. They have symptoms and side effects at preclinical doses of medications. They have sensitivities. They have to try. I had one client, her psychiatrist tried 11 different sleep aids before she could tolerate one that would help with her sleep, because she was waking up with panic attacks, and her psychiatrist was getting concerned about just the lack of sleep that was happening for her. And so that is the client population that I've worked with. And I see how underserved they are, even in the trauma community. Because first of all, they sometimes scare people because their symptoms can be so big. It's that combination of usually early trauma and then later shock trauma. So they might come to region.
Sorry to jump in there, Kathy. I just cut to the chase. So I've got a friend who's got fibromyalgia. It really affects her in her work, takes time out of her life. She's not responding to normal treatment. So I've got another friend that's got ME, or a friend that's had irritable bowel syndrome their whole life. They don't know why. It turns out, I asked them, it looks like they've got some stuff in their childhood that's not great. Maybe some stuff later in life, as you say, like a car accident or a mugging, like shock trauma, or, they get raped, God forbid, and then it comes out worse, and it's like, what does that person do listening to this podcast? Because I think they're pretty common, people with these sort of things.
Unfortunately, yeah. And part of that is the filtration that happens in the care delivery. We don't give good care to these folks early in the process. And so the symptoms escalate and pile up. And so that's hence the pattern where people then will have seen so many different practitioners before they would end up coming to me. The very first thing, and it's just going to be one of those weird recipes again, because it's the known thing, something bad happened or a whole bunch of bad things happened. And what needed to be done, whoever needed to show up and be helpful at the time didn't happen. And then for whatever reason, and then whatever care needed to keep going after that also didn't happen. And then here we are, you're 40 years old or whatever, and you have these symptoms. We have to go back to the beginning and get the thing on board that's missing, which is what I think of as foundational regulation. The details of the why and all of that are not that important.
Yeah. Why is a waste of time in coaching? Total waste of time.
It's like we could, that story, it might be entertaining, it might be helpful for you to talk about it, but it's not actually useful in the specifics of the early treatment. It will become useful later. But in the early treatment, we just have to get your physiology to stop running amok. That means we need to get the immune system settled. We need to start limiting the overreactivity. We need to get the autonomic nervous system settled. We're kind of in first aid, but we're going to do it in a slow, methodical way over a long period of time. And I call it there, honey bun therapy. So it's just like, there, sweetie. Everything's fine. All is well. I know everything inside there is running around in circles saying, we're all going to die.
So soothing, no big steps, just helping people learn self-regulation. Not like a big, we're going to get this charge out of the system or we're going to make a breakthrough, but just gentle, helping them chill the fuck out.
That's right. And my way to do that is with touch and somatically. I like to go into the signaling system, so I tend to start by working with the kidney adrenal system. Yeah. Invariably, I'm going to work with the digestive tract because it's the biggest interoceptive voice in the body that says something's wrong. When the gut isn't working, as I said, the polyvagal theory informs us that the gut is one of the first places the alarm is felt. So if we can get the gut to calm and stop sending feedback that says there's something terribly wrong, we're going to just get their system. It's not so much about settling. It's about, and the way I put it to them is, we need you to be able to do a little bit of something and then stop doing it. We need punctuation in your response system. You're like the person who falls down a flight of stairs where there's no landing and you just keep falling and falling and falling and falling. Yeah. So whatever, it's the way you're thinking, it's your physiology, it's your rage, whatever it is, gets started, and then there is no automatic interrupt. So what we need is some way for your system to begin to do something and then settle out of the doing of it. And when we start to see that on board, that's my language for talking about we've got some capacity for self-regulation. We're going to see, we might do that for months and months and months, and we will start to see some abating of some of the symptoms because we will begin to see a shift in the underlying physiological systems that have been ringing the alarm continuously for so long. We're going to start quieting those alarm systems. When we get that on board, then the specifics might become important. Then we're looking at the themes of powerlessness, the themes of not being heard, the themes of always being ready to protect, whatever that person's theme is. That may be when they're also working with a therapist or a coach or somebody else to address the skills that they didn't get a chance to develop because those themes were so big. If it was dangerous to speak up for yourself, it's really hard to just know how to speak up for yourself. You probably need help. You probably need coaching.
To retrain that as a skill.
Exactly.
They know to speak up, to ask for what you want. The basic kind of, this is where the coach comes in. So Kathy, the worry I have is this. You're an expert body worker. I'm sure if I sent any of my friends to you, they'd have a great experience. They'd heal. There's not that many of you and you're expensive. What do normal people do who, like, I've most of my friends that have these things, and I can literally think of a whole bunch now. They're all broke because it's interfered with their work.
That's right.
What do they do who can't afford 20 sessions of, gentle touch body work from someone expert like you? I mean, I'm in a lucky position. I have gentle body work every week. Rosen method, craniosacral. I love how soothing it is. I love that it's really gentle and non-invasive. On top of that, I do a therapy session. So I'm spending like £200 a week on this, right? I can actually afford this stuff. Most people can't. So what do they do?
Well, that is a challenge. And it's more of a challenge in the United States where there's money affiliated with everything like that. What I'm doing is trying to get as many people trained in this as possible. There's more and more resources becoming available in terms. I'm actually just writing a foreword for a book that's going to be coming out that has really good exercises for people to do for themselves.
Yeah.
I encourage, and what I did is I donated 10% of my practice forever. Many of these clients that I saw for no fee because they weren't working, they were on disability. And there was a group of us in the San Francisco Bay Area that were doing that, where we created a kind of a community services just amongst the individual practitioners. And who had, we would stay in contact. Who has an open space for someone who's at the low income end of things and either reduced fee or no fee? That was our little contribution, because you're exactly right. What is the bigger access to these kinds of methods? We aren't there yet, again, in the care delivery system, that they're available in the sort of average access that someone would have.
We can't get them in the NHS in England. That's not.
That's right. That's right. And generally speaking, it's unless someone's doing this under another umbrella, if they're a physical therapist where that's paid for and they're adding this in, we're in the same situation here. And it's just, it just frustrates me that you have to be a person of privilege in order to get access to healing. That's why for me as an individual practitioner, I did what I could about that. But we need, at a broader treatment culture, some change that gives access. It's beginning to happen a little more. Like mindfulness is one of those ways it's starting to work its way out. It's not enough for someone who fits in the category of what we were just talking about, but it's a start for some people. Online resources, some of the stuff that I read is doing, it's getting it kind of cobbled together right now. It'd be great if you could say, here's the thing to do, but I don't see it yet, as frustrating as that is. So it's kind of
for me, it's sort of like public education. It just needs to be like, the reason I support public education is because I want clever kids to be able to have a leg up to do well for themselves and then pay more tax and do well for all of us, and the same thing with healing. I want, any kid that's been hurt to be able to get healed so they can actually contribute to society as well as just for their own benefit. There's a really good conservative case, I think, for this, let alone liberal case. So for me, it's just the basics of a society that you need those, like the public healthcare, the education. And I long for the day, shall we say, when it's just a normal thing people can access. Like in the same way in the NHS, I can get antibiotics like that if I have a throat infection, like that would be amazing for this kind of work. Yeah.
And we're just slowly inching our way in some of those directions in certain systems where there's the beginnings of inclusion of somatic awareness, the adverse childhood experiences study. I hope it's beginning to have an effect in the judicial system. It's beginning to have an effect in the medical system. Do we have ways to make this more broadly available to people is going to be the question. Because if you just looked at the dollars and cents, it would be cheaper. I had a colleague who ran the smoking cessation program at San Francisco General Hospital. And with one patient that they got to stop smoking, and there's often these comorbidity issues. So if you're smoking, you're more likely also to be using drugs. So getting the person off drugs, off cigarettes, saved the one hospital $100,000 a year. And this person was indigent, so they were not paying this themselves. Those are just the costs the hospital had of providing treatment for multiple hospitalizations for this person before he stopped using drugs and cigarettes. And then when he stopped, that's what they saved for one person. So the costs alone should be pretty convincing.
Right. If you look at the effects on the workplace, on crime, on, all these other areas where there's knock-on effects because people are, in trauma symptoms. I'm with you on this one. I mean, what is like something you'd really like to clear up around trauma? Are there any sort of misunderstandings that you've seen creeping in that you go, hey, everyone's a freaking trauma expert now, right, Kathy? So is there anything you want to kind of clear up as an actual trauma expert?
Well, I think there's the two sides that we already talked about. One is not everything is trauma.
Yeah.
So I think we devalue the experiences by naming as trauma things that are that are just about being uncomfortable or being afraid, but not in a way that has altered your ability to be in the world in a more natural way. Yeah. But on the other side of it, we need to understand that what we think of as daily experiences can actually be the source of trauma. A car accident, a surgery, an extreme level of fear that might happen. As you said, a bank robbery. And we don't know. And this is one of the fabulous things that the biophysiological models of trauma, if you want to call it that, have helped us understand. It used to be they defined trauma as extraordinary events. And Judith Herman way back when was saying, but war is not extraordinary. Domestic violence is not extraordinary. They're commonplace things and they produce these symptoms. And so really taking the content away from defining trauma and saying it's really about how that person responded to it.
Yeah.
Have they responded in a way that means their life is interrupted, their ability to be in their life is somehow or another disrupted. Their physiology is no longer responding in natural ways to the potential triggers. We can't say that no one in that bank should have PTSD, and we can't say everyone in that bank should have. It's going to really be so based on their individual experiences, as you said, maybe the coincidence of what happened that morning before they went to work that will, in a way, determine some of that outcome. So we need to see people as individuals about how trauma has impacted them and not just base it on the content of what happened. Now, we get into these things where there's compensation. And so they place value on certain types of experience to say you should get more money because that thing happened to you as compared to that.
Yeah.
I get that, but we don't have to adopt that in the treatment culture. We can
Such
be
a fine line, isn't it, between those two extremes? On the one hand, everything's trauma, devaluing it, making a culture where people are running to their employers at the slightest little thing, saying their colleagues traumatize them. Some of the weirdness we see around now. And on the other hand, also acknowledging hey, we had an episode of Jane Clapp and it's called Everyday Trauma. The trauma of just experiences of overwhelm, of little car crashes. I mean, who hasn't had a car crash? Do you know what I mean? Yeah. Your chances of being a victim of crime at some point in your life are relatively high. And robbing banks is also...
And institutionalized oppression. So, we have to understand in certain cultures, we are creating this sort of crucible of trauma by the way we respond to, I don't even like the word differences, because if we have a wide range, we're not seeing this as differences. We're just seeing this as a range of how human beings can be. But if we isolate any of those supposed differences and start making that person somehow or another at fault or separate or other or somehow not included, that can have that same cumulative effect that will be invisible to those of us who haven't had those experiences. So we're at any given time when I'm sitting in a room full of people in a training, and this is particularly true with the somatic experiencing trainings because they tend to be fairly large, I know there's a whole bunch of people sitting in that room with invisible trauma. They were abused as a young person. They've experienced, they are of a different gender expression, and they were made to be felt like they were less than. There are somewhat visible versions of trauma where you can have a guess about what happens to the person because of their appearance. They have a physical disability or something. And then there's all these invisible versions where we don't know by looking at somebody.
This is a big deal because I think we're recognizing some of the more visible ones. Like if I think my friend Natalie, who I went to school with, she was like the only Asian girl in the school and probably always felt slightly other, and she didn't kind of have any violent, attacks on her because of this, but she had every day a slight feeling perhaps of being sort of not like the other kids in the school, but that's quite visible, and you could see her and go, okay, 1,000 white kids, one Asian kid. Okay, she might have something going on here that's difficult, but then you don't necessarily know who's got a drunk dad at home, or who's from an immigrant family but they're white, who's from a Russian background and they've got all sorts of trauma from that. You just don't know, right?
Someone who has a learning disability and they've struggled their whole life and they've been made fun of that they're stupid, and here they are with all of that load in there of their self-experience. That's, those are the things for me where it's just finding that balancing act, as you said, is not easy, but at the same time, we can't presume by the way someone looks that they haven't had trauma in their history. And that is the thing about the adverse childhood experiences study. It was done within a health delivery organization that the vast majority of people that belong to that organization are employed. And by chance, in the region where they did the study initially, it was primarily middle-class, white, employed people who participated in the study. And yet we saw these levels of trauma in their history. And I think that really means we need to be considering that maybe the idea we have of who is subject to trauma, or that we can see it.
Yeah. Yeah.
You know, like you said, we can make those assumptions about someone's race, and, you know, we might have some pretty good guesses. We can't necessarily make that assumption in just the way the person appears. And very often with some of the clients that I worked with, they were high performing professionals. They felt like charlatans. I know that you encounter this. They felt like charlatans. They felt like hollow people because that what they put out as their facade, they didn't feel that inside. But even someone's ability to be out there in a high pressure work life doesn't necessarily mean how much that you know how much they're suffering.
Massive overcompensation. Sometimes they're using their hyperarousal to work 12 hours a day and overcompensating for their insecurity by being massively successful. I mean, there's all kinds of ways that, you know, accumulating money because they feel like they're going to starve. You know, there's all sorts of ways that can go. Listen, we need to wrap up, unfortunately, but I want to do one fun thing to finish, and then we'll go to like your websites and closing message. So, how would you write a Valentine's Day card in the most scientific, trauma-sensitive language? So, for example, like roses are red, violets are blue. I want to co-regulate with you, like because people are using this like scientific, you know, language now. So, do you want to write a little love poem like that to the world?
I like, you know, the roses are red, violets are blue, even though they aren't.
Or what would be like a chat up line that you could use? Like, you know, like you're in a nightclub, it's full of therapists, and you say, "Hey, baby, my ventral vagal nerve is stimulated." Like, what would be?
Someone once said to me, "You have a really fabulous nervous system."
Look at the nervous system on that. Whoa. So, okay, I'm sure we've upset some Portlanders. I joke, but this is just sort of the way this is spreading right now. You know, like sometimes my colleagues will say things like, "Oh, we're really co-regulating nicely in here." I mean, you mean we're getting on well? Yeah. So
that's right. I don't tend to think like that. So this is like a brain cramp for me. I don't know.
Okay, just a fun one.
You seem to be at a whole other evolutionary level. I don't know. So your ventral vagus is really working right now.
Yeah, your ventral vagus is working for me. Well, this has been effective co-regulatory synchronized nervous system activity, Kathy, which means I've enjoyed it.
With appropriate vocal prosody.
There we go. There's my next line. So I think it is important. This is what I got from actually most of my Jewish trauma teachers. The ability to laugh at some of this stuff, I think, is actually potentially very healing and useful. So even in the trauma episodes, try and bring a bit of humor in without any disrespect to anyone. Okay, so where can people find out more about you? This has been brilliant. So, like, where do they go to?
They can go to my website, which is somaticpractice.net.
And that's spelled Practice, like the practice, not as in practicing.
That's right.
I argued with my editor about the spelling of this, so I now know how to spell practice. Okay, somatic practice with a C.net. And any other resources? I found a couple of other interviews with you online. On YouTube, I found you.
The two books that have come out most recently, one called Nurturing Resilience, which actually has quite a lot of information in the category that we were talking about, even for people who fit in the client category. I think useful information about the impact of early trauma. And another book that was co-written with my colleague, Steve Terrell, and another book co-written with Elaine Duncan called The Tao of Trauma, which is overlaying a traditional Asian medicine perspective on trauma responses, and also has really useful exercises in it for people who fit in the client category. Both were written a little bit more for practitioners, but they're pretty, I think, accessible for people who don't have a technical background.
Nice. And I really enjoyed this. Do you have a closing message about the body for all our listeners?
It's really great if we, settle in and take up residence.
Take up residence. That's what we want to do.
Yeah, most of us have moved a little bit more into our brains and might be very helpful. So some somatic presence, I think, would be really helpful these days, particularly.
It's a great closing message for the Embodiment Podcast. Kathy, thank you so much for your time.
My pleasure. It was great to chat.
some ways to get more, to give back, and to get more involved now. So the biggest request I have would be to share the podcast with your friends, people that you think would really enjoy it. Email it to them, put it on your social media, tell them about it, old school. Really appreciate that. Equally, if you want to support us financially, you can go to Patreon. That's patreon.com/Embodiment Podcast and give us $1 an episode. And I'd say they're well worth $1. So that's less than £1 if you're in UK-ish. So yeah, please go there. On the embodiedfacilitator.com website is where this is hosted. If you're, most people I think listen to for iTunes. iTunes, we'd certainly appreciate a review. The way iTunes works means that a review means more people will find it. iTunes regards it as more important for searches. So even a couple of sentences review really does help as a little thank you to us. And if you want to go to embodiedfacilitator.com, you can see the actual, links to the sites. There's comments on there. The Facebook group tends to be where people discuss things. So if you go to put in the Embodiment Podcast into Facebook, there's a page which is relatively quiet and a group which does have some discussion on. So I will reply to things personally there. So also on embodiedfacilitator.com website, there's all sorts of freebies there. There's videos, there's free ebooks, there's ebooks you can buy. And of course, there's our newsletter list. If you want to stay in touch and learn about things like the Embodied Facilitator Course and our next Embodied Yoga Principles teacher training, then go to that website and you'll see a little pop-up and you can get the newsletter through there. Okay, so I think they're the main ones. Tell your friends, pay us some money on Patreon, give us a review on iTunes, send us your email if you want to be on the newsletter list, and get involved on the Facebook there. Bit long. Pick whatever you like that works for you. Until next time, welcome home to the body.